Uh, Good morning, and thank you for joining us on this rather interesting webinar, if I may say so, because it doesn't talk about disease and instead talks about things that many of us grapple in our minds. And as I was preparing for this, I realized how much more there is that needs to be done for most of us, that including myself. Sometimes we get stuck with clinical care. We run through the day. At the end of the day, we are ready to go pop in bed. Very little do we spend time on thinking, what can we do more? And at some point of time, just seeing patients the same way, day in and day out, is probably not sufficient. The mind, the mind that craves for something more, an intellectual freedom, being able to do more for our patients by not just providing good care, which is very important, but improving ourselves, contributing to knowledge, contributing to society through advancement of knowledge. This is really what scientific temper is all about. This is my this is a person I probably idolize the most, Dr. Richard Feynman, who probably was instrumental in shaping my belief over many years. Dr. Feynman believed that science is the belief in the ignorance of experts. A very, very provocative statement. Basically, he's challenging you to say that whatever this is there, that it is probably even more important to challenge even if this is an expert. Not challenging is not just being argumentative, as most of us believe, but by not taking what is written, what is published, what is spoken as the gospel or dogma, but taking it from a scientific approach, which is with a good sense of skepticism. So, what is scientific temper? How do we cultivate it? I'm going to spend more time on research today because that was what was asked of me: how to create a research temperament. But remember, unless you have a scientific temperament, you can't get a research temperament, can you? So, the most important part of the scientific temper is to question, to observe, to test, to hypothesize, to analyze, to communicate. I think many of us are doing this on WhatsApp groups right now because there is so much information that is coming up on COVID. Each one of us our own pet theories, most of it not based on evidence. A lot of people, I was just observing the other day that when it comes to emotion, evidence is sacrificed on the altar of emotion. It's even more important to be very evidence-based, to be questioning, not accept everything that a pseudo-economist or an epidemiologist dishes out, not really believe every mathematical modeling or fancy words that are put, but actually to have a skepticism, at the same time not being cynical and looking at evidence carefully. Indeed, looking at evidence carefully without being emotional and being able to analyze data is even more required in a pandemic. So, what constitutes scientific temper? One is a healthy skepticism. That whether that particular piece of knowledge, that particular piece of information, uh, that particular piece of information that is provided, each of these are these true? Do they apply to our population? Is there something else that needs to be done? Second is a reduction in bias. That we don't bring in our own views when we examine the evidence and in fact look at things, which is the third part, objectively. Third, of course, is open-mindedness, that you can actually see things differently, to be able to accept contrary views. Of course, humility. Unless you're humble that we don't know everything, that we are not the be all and end all of it, and we have the ego to say we don't know. Scientific temper doesn't result. To be able to be rationally looking at the same time, an importance is a positive approach. That there is a problem, there's a solution, that we can find it, that we can work together, we can look at it. I think that's very important instead of being negative. I sit in boards where people tell me that this cannot happen, that cannot happen, then it can happen. Lastly, willingness to share information. Willingness to share information is probably the most important part of this whole thing. So again, remember, this is not a COVID talk, this is not a disease talk. We're not here to find answers to COVID and other places, but actually to see how we can improve ourselves in these forced lockdown. How can we develop a scientific temper? How can we start contributing in terms of research? And many of us who have so many patients, when we see articles in the journals that have 20, 30, 40 patients, we think, oh, why is it that I have not done it? I have so many patients that can be part of this, and we don't do this. So how do we develop a scientific temper? So let's go on uh, and understand. Many of us will also say, why should I do research? I am part of a small, very, very a small clinic. I don't have the time, and why would my research matter? Here is a very old study. This is 1996, and what it shows is what happens in there are 1,000 patients and 800 have symptoms. Only about 300 to 350 seek medical care. But if you go way down, less than 1% goes to a hospital, is hospitalized, and a very, very small number of people visit a hospital. Most of the care is provided in a clinic. But if you realize that most of the studies are done in hospitals, in tertiary care centers, in places far removed from where actual care is provided. So really, one of the best ways to do things is is to make sure that we actually provide care and do research at the place where care is provided, which is most of our clinics. So how do we provide research in the place of care? Can we do it? We have so many patients. We don't have time. Can we do it? The answer is yes, if that's what you want to do. So why move beyond clinical care? One is to contribute to society. I think each one of us needs to provide that scientific temperament that is required to contribute to society. The second is is for the intellectual part of ourselves. We are doctors who learn throughout the year, throughout our lifetimes, and unless we contribute in such a way and not just mechanically see patients, there is no benefit. Third, over a period of time, we accumulate so much more information, so much more wisdom, so much more perspective that needs to be validated and brought into and other people can benefit. After all, when we are gone, what do we have left behind? A legacy. The legacy is our expertise and our wisdom needs to be translated for the next generation to be able to use. All right. So these are some of the reasons. So what does it take? What does it take to actually do this? The first, of course, is to think about patient care not just as a chore that needs to be completed. That from every patient we learn, from every patient we have questions, that each patient is unique, each patient provides a set of problems that needs to be identified, and in the care of each patient, there is a research question that needs to be answered. Why is it that this patient has less number of symptoms? Why is it that you take the COVID situation? Why is it that some patients are more effective? Why is it some patients don't do so well? Should ACE inhibitors be stopped? Right? So unless we observe, we don't get the questions. Being observant, being thoughtful, And the word that is used in many of the meditation cycles is being mindful. That are we mindful of what is happening? So being mindful of the surroundings helps us develop research questions. A patient presents with arthralgias. There is nothing else that you can see. It is very short duration, but recently somebody have started a DPP4 inhibitor. Is there a link between arthralgias and DPP4 inhibitors? Here's a patient who presents with a new rash. Is this something that we have to look at? The second thing is being very conservative about documentation. Many of the times we don't look at documentation as an important part of our life, but having the discipline to document helps us take off in a research system. You can do it physically. You can do it through an EMR. I want you to know that you don't need a fancy EMR. Before I designed my own EMR, I'll show you in a moment. But in the past, I've just used an Excel sheet to document, and just to show you that being very physical, making sure that you have a problem list, making sure you document symptoms, and that allows you to develop a research temperament. And that discipline of documentation is very important. Vigilance, of course, is something that's very important. Reviewing the drug list, making sure that every patient whom you prescribe a drug has an opportunity to review it the next time gives you vigilance. For example, a patient has presented to the hospital with an arrhythmia. This patient is taking hydroxychloroquine, and someone has added azithromycin on top of it. And patient's diabetic has been on hydroxychloroquine, and then he had an upper respiratory infection. He's also on let us say uh, teneligliptin, and somebody's added azithromycin. Guess what would happen? QT interval prolongation. The question, of course, is so that is vigilance. Being able to question, being able to question is something even more important. One of the reasons that most of us don't have the scientific temper is that we have been brought up by a question called what. If you take your final exams in MBBS or all your MBBS exams, every question by the examiner always asks what, right? But the truth is, we need to start asking how or why. And the highest part of questioning is why not? You know what? I don't think that this drug is working for this patient. I'll give you an example. Patient is taking canagliflozin with heart and for heart failure. We know that metformin and canagliflozin have the same mechanism of action in AMP. Is metformin reducing the effectiveness of canagliflozin? Why not? What if should I change the medication? Is there evidence in the literature to show that this is how it is happening? Questioning our own beliefs. I think that milk at night makes me sleep better. Is it true for many of our patients? Can I design a research project around it? That's it. The second important thing is the last important thing, and probably the most important thing in all of this is the discipline. The discipline to observe, the discipline to document, the discipline to question, the discipline to keep doing it again and again. As Aristotle said, that excellence is not a virtue, it's a habit. Right, let's take this forward. Let's see what it does. So I have only a small clinic. Can I still do research? So research is big. For example, you could share a small case report of something that you have seen. For example, many what the simplest thing is to have a good camera in your clinic. Use it. Also have a photographic consent, because you can't do anything without consent. But let's say you see an unusual a skin lesion. Take a picture. Today you could use. There are many apps that are available that you can just take a picture of it, and those apps will tell you what is the most likely diagnosis. If it doesn't fit any of this, and your dermatology colleague also feels that this is not it, and let's say it's associated with a drug, you have a case report. And there are journals that do only case reports. Let's say you're in an endemic area of fluorosis and you've discovered some new pigmentation that occurs in the teeth. That becomes a case series, right? And today's world, many people do questionnaire based research. A lot of times, the patient's values, the patient's feelings, the patient's quality of life, each of these are important. Let us say you started two new drugs and you're combining drugs. Does the quality of life change? Does the economic outcomes are different? Does the patient become better? These are questionnaire based. Sometimes you can find you can find out questions based on surveys. For example, how many of you have talked? How are all your colleagues using metformin as a first drug? In somebody with heart failure or in somebody with coronary artery disease, are they starting an SGLT2 first or are they using metformin first? Right? How many of you people use a connected glucometer? So many of these today surveys, patient values, patient-based research, how they perceive things can all become a research project. And the patient interface is increasingly becoming a very important part of research. QI, which is quality improvement, is another way to publish. Many simple quality enhancements. For example, I saw a research where they said, does does keeping a YouTube video about insulin usage, does that improve risk of hypoglycemia or correct usage techniques? So people want to find evidence to very small questions, and if you're able to do that, then that becomes a publishable research. Then the sky is only the limit. It's not like the olden days when there are very small number of journals. There are lots of journals, many online only journals. And there are specific journals that look at quality improvement, that at cost effectiveness, at healthcare surveys, each of these. Of course, if you're in the bigger league, you can do post-marketing surveillance, which is a phase four study that lots of people actually do. And of course, real world evidence is, we'll talk about it in a moment. And then if you've gotten really set it, there are lots of things you can do in contracted research. So it's not necessarily RCTs, it's not necessarily the big stuff, but anything that you do, if you do it with observance, with vigilance, with discipline, and with documentation, can become publishable. And the average Indian doctor who sees 40, 50 patients a day, if he or she has some degree of help and can actually document its work, getting a case series that is larger than any Western case series is much higher. Okay, so where does this come in? So one is the relevant scientific. One second, I'm just going to use. So this is where EBM comes, and this is where your clinical judgment comes, relative and scientific evidence comes, patient values and preference comes. Really, each of these, including clinical judgment, are areas where research can be done. Example, what do patients like? What do they value? What do they prefer? For example, use of telemedicine. Now, all of us are starting to do telemedicine. A simple question is saying, what are the things about talking to their doctor they like? What is it that they don't like? Do they feel satisfied after a telemedicine consult? What is it that they would like to improve? That becomes a very good publication. Physician's perception of how to do telemedicine, that becomes a publication, right? Clinical judgment, how in a given situation, what would a doctor do? That is a publication, right? So that's how things work. Next. So what can be researched? Clinical data, how clinicians practice, how disease behaves. For example, DPP4s in South Indians versus North Indians, people who take rice versus wheat, those who take fish versus no fish. For example, there's some data to say that people who eat fish, their DPP4 response is much better. And all it takes is to look at it. And I'll show you one of the simple ways is to collaborate. What you can't do alone in your clinic, 20 of us can do it together, right? Treatment preferences can be a clinic. How the community perceives it can be a research. How the family looks at it. For example, what about family support in patients with diabetes? I had a simple project going that was funded where we looked at, what happens when you educate the family and give them the vigilance about the patient's diabetes condition. And it showed that when the family was involved, it is much better. A simple study that one of my colleagues, Dr. Vidya, did was something absolutely fabulous. What she said was there is a lot of people who can't walk or who can't walk for long times. What if we taught them how to walk for 5 minutes, 6 to 10 times a day? And what she did was she fixed a pedometer on these people and actually showed that the A1Cs were lower. It didn't require a big institution. It didn't require many things to be done. It was a very, very simple study, low number of patients to show the benefit. And of course, that can be blown into a bigger study later. Then, of course, this is real world evidence, is where which takes it to the very next level, where it takes large databases and then it takes your clinic conditions or an insurance company's conditions, and then using the power of modern technology to do design and analytics, it generates and says, so while a randomized controlled trials would tell you that can it work, the real world evidence tells you, does it work? Does it work in our clinic with our patients, with our kind of adherence, with our kind of time plans? And remember, the big database in the world use very simple stuff like insurance data, prescription filling, uh, body mass indexes, weight, high blood pressure. They don't even go as deep into EMRs. However, if people can start doing small things, for example DPP4 inhibitors in South Indians, DPP4 inhibitors in fish eaters, these are things that multiple people can collaborate and can start doing. I'm just giving you examples, and we'll do more examples during the question and answer session. But the whole idea is to sort of tell you that it's possible to do it in your clinic. The idea is to give that kind of positivity that is required. So what do you do? The first thing is ask a question. Unless you ask a question, you're never going to find an answer. And I'll tell you how to ask the question in the next slide. But the important thing is, a lot of times we get carried away saying, how do I do the statistics? How do I do this? How do I write a paper? I think all of that is actually the easiest one. How do I get the funding? That's also easy. The most difficult one is asking the question, asking the right question. We'll talk about. And then finding out what is the existing answer. The existing answer may be right. It may actually tell you, okay, you don't need to go forward, or it may not. It may not have an existing answer. For a lot of things, there are no existing answers. Are there any predictors for what requires an antibiotic in the outpatient setting for somebody with sore throat? There is a clinical answer from 20 years ago. We don't know about what it is in the modern era, right? Does gargling with salt water help ease symptoms in a URI? I saw a study that looked at with honey and water at bedtime, does it allow children to sleep better? So the simple thing is, a lot of times even you can even question home remedies. Do home remedies work for URIs? Nobody's published that report, at least from an Indian context. It's very interesting. So first ask a question and then do a search, find out the existing answer. In your practice, you may have seen that that answer is not the same as what you think is right, right? What the literature may say was probably asking in the Western literature. Maybe in India the answer is different. Think about it. Is your answer different? If you say think yes, talk to your colleagues. Are they seeing the same thing? Are they seeing different things? Write a small review of what you found out. Then write a question. How do you write a question? I think this is a simple way to write a question. This is called PICO. The population, patient or problem, right? Intervention or exposure. What do we do with them? What are they exposed to? How do you compare them? And what is the outcome? For example, in patients with type 2 diabetes who present with dry cough, do herbal remedies in comparison to alcohol-based cough syrups have the same outcome when it comes to symptoms? It's a simple question. In patients with type 2 diabetes, and bad breath or halitosis, thus the use of topical metrogyl when compared to with gargling improve the outcome, right? You don't have to have fancy questions or big buckets to do research. Simple things in clinical care that you always wondered, does it work? It's a good idea to do things. Okay. So has someone else done it, or is someone else doing it? If it's not there in literature, you could always search for in the clinical trials registry, and you will find, and this is the ICMR's clinical trial registry that tells you such a trial, and all clinical trials today are registered at the ICMR. So then, how do you proceed? This is when you probably need some help. You could get a statistician. You could go to an online thing where you can calculate the numbers needed for a positive event. Remember also, if you're just doing a proof of concept study, you really don't need big numbers. Just start, just start doing a pilot project, and then you can always do it. The second thing is collaborate. Start working with people. You notice that working with people and and today we've all learned how to use Zoom, we've all learned how to use Google Hangout, we all do WhatsApp video calls. You don't have to leave your clinic to collaborate. And of course, funding is something very important. We'll talk about it. Then write down what you need to observe. How do you document it? For surveys, a simple Google form is very useful. Don't try to collect too much information. A lot of times what happens when we try to do research is that we want to collect everything in the world. Then what happens? We lose interest, we don't have the time. For example, we did a study called the START study where all we did was to calculate the creatinine, the weight, and the BUN in patients with type 2 diabetes. We didn't even look at HbA1c. But that was a simple study that we wanted to get done in our clinics, and that actually got published. So these are things that you want to think about when you do this. And of course, consent and ethics is actually very important. We'll talk about it. How do you fund research? For small projects, I guess you can fund it yourself. A simple questionnaire doesn't need funding. A simple survey doesn't need funding. Then there are other things that where interest groups will fund. For example, let's say you have a bunch of patients with Turner syndrome, and they want to find out what is the quality of life in patients with Turner syndrome. The interest group itself may do it. Societies, the Endocrine Society, the Cardiological Society, the Tamil Nadu Endocrine Society, all of these are small amounts of funds that you can do that for this thing. All you have to do is to write. They may say yes, they may not show yes, they may not say yes. But there's no point, there's nothing wrong in getting thrown out. Many of us who do research, our first 5, 10, 15, 20 grant applications were all thrown out. Pharma has a lot of money, and generally they are throwing it away in so many things. It's a good idea to ask them, you know what, I'm going to do a small research. I'm going to find out whether in Indian patients, just washing the genital area reduces the risk of after every urination, reduces the risk of SGLT2 induced genitourinary infections, right? And of course, you reach a big league. There are ICMR funding, DBTs. I don't even want to get there. That's not the kind of talk I'm giving today. We're just talking about how can you do it in your small clinic, right? Then, of course, today lots of digital stuff. People have apps. One of the interesting things that people are asking is, let's say if there's a patient who's got a connect who downloads a digital app. How long is it that they actually use? A lot of us think apps are very good. The thing is that at the end of a month, most people have app fatigue. However, today a lot of stuff can be measured. Heart rate variability is measured through an app. You can detect arrhythmia through an app. You can detect emotions through an app. For example, a simple way to look at this is there a correlation between a patient's eating habits and their heart rate? If they have stress, do they eat? So let's say they have a heart rate monitor that's in their wearable technology, and you ask them to document when they are eating and make a correlation. before the time that they're eating, did their heart rate go up? Did they snack? So today, thinking about digital technology and wearables can also give you very, very cost-effective things that nobody else has ever thought about. All it requires is to be observant to what people do and how society changes. Okay. Is WhatsApp an effective way of giving consults? Are patients more comfortable with WhatsApp than a telephone call? Each of these are, nobody has ever published some of this information, and it's very easy to get. Just to remember that most studies require consent. Retrospective data does not require. I put in this one. And for most of us who don't work in big institutions, aligning ourselves to an independent ethics committee is something how that works. Independent ethics committee function outside of institutions. It has to be registered, and there are many in each city, and people can help you find that, right? They should have an SOP, and all you need is to send things to it. Generally, they will tell you not, they will exclude you if you're doing retrospective data and stuff like that. But even there, I think consent is important. Never use patients' private. They never take patients' privacy for granted. Always make sure the patients' eyes are covered. That for a photograph, you've always taken a consent. That if you're planning to do a survey and you're planning to publish it, that you've actually done a consent for these patients. You don't have to do fancy stuff. It's all very, very simple that you can write up. There are people to help you, but this whole thing is to sort of help you feel that you can do the research. Once you start doing it, you will learn a lot more. You will read a lot more, and it's probably easy to do. Lastly, people are always worried about where do I publish. When I started out, there weren't many journals you could send to, but today there are hundreds and hundreds of journals. There are also exclusive case report journals. There are many open access journals where you pay, but your research is free. Interestingly, there are lots of primary care journals that actually take up stuff. In the starting, don't get worried whether it is PubMed indexed or Copen or what is the impact factor. It's the idea to get your foot in, and then slowly things will work. Remember that the worst thing that one of the important things that happens is during the peer review process, people can be quite brutal. That they will tell you that your research sucks or it doesn't meet. But most of the time, peer review is a way that you improve yourself. People will say all sorts of things, but what you really want to do is to see how we can improve. All right, but never be afraid of this. So to take this forward, first thing is keep an open mind, document what you do, find collaborators, work with other people, keep your eyes open, and importantly, don't be afraid of failures. If I can do research for my clinic, so can you, and so can everyone. I think it's important to understand that the research temperament starts and that we keep on questioning ourselves and see how we can be better. Research or good scientific temperament doesn't require you to be abroad in an Ivy League institution. In your own place, in your own clinic, by just being open, by just being willing to make changes, by willing to go that extra effort in changing ourselves, we can all become good researchers. Thank you for your patience. I thought I'd just give you an introductory talk into this because many of us have a problem uh, where we don't want to do these kind of things. It's mostly the inertia that we have, the fear that we have that we won't succeed. Don't be afraid of failing because failing is the best way to succeed. Thank you so much. I'm very happy to take any questions. Thanks for listening to a different kind of talk, and I'm happy to answer any questions that people have. Okay. Do we have courses where we can learn how to do a? Can I have the questions, please? Yes, please. So a question. Do we have courses where we can learn how to write paper and research work? Absolutely. Most medical schools and there are online courses. One of the things I would like you to look at is in places like Coursera, where they actually have courses where you can get a certificate. Yeah, there are ICMR certified workshops that are available. Once you start getting into this, the sky is the limit. My suggestion is at this, but the first point is don't get bogged down into the methodology. First, start writing good research questions. Once you start writing good research questions, your methodology flows, and also, of course, make sure that that you get help, a good mentor, someone who's willing to guide you, people like us who are there and available in every specialty. There are people who will be willing to guide and help younger people or colleagues to come up. But don't be afraid of this. And and the reason I say don't get into a methodology workshop right away is because it can be quite intimidating. Statisticians will start throwing a lot of names and numbers. The truth is, you can hire a statistician to do your statistical work. The important thing is the clinical work, the clinical questioning, how to take care of those patients, and then collect the data. In general practices, where space is a premium, is it possible to bring some basic principles of protocols in the post-COVID era? It's probably possible even in the pre-COVID era. It's just a question it's just a discipline that we do. For example, make sure you ask the same questions. Make sure you document it. Make sure you follow guidelines. And today there are more guidelines than we need. But and you don't have to choose every guideline. Choose the one that fits your practice the most. The way I look at it is choose something that you're comfortable with, that suits your patients, and then stick to it. Then you can always evaluate it and see. Let's say you've done it for 3 months or 6 months, and then you evaluate and see, does it work? Does it have any problems? So one of the most important ways of scientific temper is to assess your own practice. Take a protocol, stick to it. At the end of some time, review it and see, okay, is this work for me? Maybe patients are, so you can evaluate it from yourself, from your office staff, from patients. Maybe it's not working, and then you can make modifications for it. And then you document those modifications, then you publish it and say that we made the following changes to the guideline, and this seems to work better for our patients. Why nowadays digital thermometer and sphygmomanometer advised in spite of perfect result to mercury containing apparatus? Because of the toxicity of mercury. I'm not an expert on it, but because of the toxicity of mercury. There are a whole bunch of corona-related questions. This wasn't meant to be a corona topic. How to consider glucagon in treating diabetes? So glucagon, there are many ways to work with glucagon. DPP4 inhibitors is one of them. Ranolazine is one of them. There are glucagon co-agonists that are in the making, and these can be used. Which anti-diabetic drug should be avoided in COVID cases? The answer is none. You can continue it. Preventive role in treatment of corona patient, role of hydroxychloroquine and mentioned dose schedule. I wish I knew the answer to that. There have been different things to it. People have come up with some consensus of using a loading dose and weekly hydroxychloroquine of about 400 milligrams. There are several different schedules. Remember, at this point of time, none of these have level 1 evidence. All of these are basically consensuses that have been developed by various bodies. Use one and stick to one. In current epidemic patients, should we suspect all patients with azithral and hydroxychloroquine? Only in patients who are admitted to the hospital and under the care. I don't think you should use it in the outpatient setting. HCQ prophylaxis in COVID-19. There's a recommendation. We don't know the basis of it, but looks like there is a reduction in nasal carriage. What is the role of plasmapheresis in severe acute COVID-19 disease? The answer is probably a plasma exchange has been talked about. Convalescent serum has been talked about. I'm not aware of plasmapheresis. There are a whole bunch of things that work in the cytokine storm of COVID-19, steroids being one of them. There are questions for and against to it, but I think many experts start using steroids and not plasmapheresis. Repaglitide in the management of diabetes fairly. I have very limited experiences It's quite an expensive drug for being a sulfonylurea alternative. So I don't use it much. Is there any alternative to lockdown to combat COVID-19? People have tried herd immunity by exposing people to COVID-19. Obviously, they switched that particular tactic. At some point of time, we may have to consider letting the healthy people get exposed to COVID-19 to develop this thing. Over a period of time, hopefully, there is going to be a structured coming out of the lockdown, but preserving the vulnerable. Remember that whether this was BCG related or other factors, India has a very low penetrance of the COVID-19 infection. Right. How to frame clinical research in diabetology? All the things that I talked about. It starts with a question that you want answers from. Use the PICO framework that I said. Before starting clinical research, does it require permissions from a government body? No, from an ethics committee. You don't need a permission from a government body. And remember, for some things like retrospective studies, you probably can get away without even that. But my suggestion is submit it to an ethics committee. What are the minimum requirements in clinic to start a clinical research? Just you and patients. So there are no minimum requirements. All it takes is for you to have the discipline to document, to ask a question, and do things. All right. Any special relaxation and control of blood sugar in elderly and corona scenario? Hopefully, no. We don't want people to relax. In fact, most of our patients, I think, are one of the things that we have been doing is to tell them, be active at home, learn some home-based exercise, don't get into snacking and junking. We don't want you to gain weight. So this is something. Hydroxychloroquine in type 2 diabetes works well. Two possible, the most important mechanism is the way it works in diabetes, of course, is by delaying the removal of insulin. But what people are very, very fascinated about is its role in anti-inflammatory. Remember, at this point of time, it has been approved for its anti-diabetic role. Uh, we use it after sulfonylureas, and it brings a modest reduction around zero point 0.6 in HbA1c. About 10 to 20% of these patients feel very weak on the drug, and we have to discontinue, but most patients tolerate it fairly well. Diabetic patients, what are the precautions during the corona wave? I think it's important to understand that diabetes is among one of those conditions that has a very high odds ratio. You want to tell your diabetic patients with other comorbidities to stay home, not to use a mask, to wash frequently. One important thing is, especially the older patients, tell them to stay away from their grandchildren. Grandchildren are generally going out, and also they don't wash hands. And the most important, and in children this can be completely asymptomatic. So please tell their grandchildren not to be with them. Take your medicines. You don't want their sugars to get. Why we Indians are not so advanced in corona vaccines and other research? Well, India is quite advanced. We are now supplying hydroxychloroquine to the rest of the world. And remember that no one is anywhere close to developing a corona vaccine. There's a lot of posturing going on. There's a lot of, a lot of battles going on in media. The real truth is that we have been stuck by a pandemic. That while we can look at microcrystals and other things, it's developing a drug and a safe drug or a vaccine and a safe vaccine is not so easy. So that's why people have started using convalescent sera. Okay, so we've had 27 questions. I don't know if there's any more. If there aren't any more, thank you everyone for your patience. I really appreciate you all for joining me here today. I hope this was useful to you, and at least for this few of you who joined us because you wanted to talk about scientific temperament and research, that this helped you to understand and hopefully inspire all of you to start doing this at your own clinics. Thank you so much.